Good morning, everyone. I am Dr. Kunal, and here is my team. This is Abhishek, this is Shilpa, and another Abhishek here. So we are we were supposed to do a left pin bifurcation initially, which will take up second. But here is a case where we have a 44 years old male, and he is presented to us with anterior wall MI. Today is day 3 of MI. He was thrombolized outside, but he continues to have exertional angina. So he's having post MI angina, and on echo he has hypokinesia of apex as well as the apical septum. Rest of his EF seems more than 45%, and we have taken up for an angiogram. Just done the angiogram. You can see on the screen. This is the RA caudal view, and you can see that his LED just forward it. This is the epicranial view, and you can see that there is a lesion. There's a tight lesion in the mid LED, which is the actually culprit lesion. So we are going to fix it up. It's a very straightforward focal lesion. The other thing which we want to just show the RA caudal view previous. This is the another disease which he's having. He is having osteoproximal disease of LCX, and there is around 70 to 80% stenosis. This is the actually point of discussion because LCX is disease from the ostium. We intend to do because as per the latest guidelines, it is better that we go ahead with the total revascularization if possible, and this is definitely significant disease. We will do the IVS imaging and we'll see whether how tight the lesion is. Secondly, we'll see how much disease is seen in the left vein. So these are the things which we will discuss when we do circumflex. Before that, we will start with the LED, and it's a very straightforward lesion. So I will reconnect once we have wired it, we have dilated, and we have deployed the stent in LED because I don't think there is anything significant to show in LED. When we will start LCX, we'll join back. Thank you. Yes. So we have just passed the wire across LED lesion, and after that we have pre-dilated. Just show the last where we have pre-dilated before that. Yes. So this is how we had pre-dilated with a 2.5 into 12 NCU for a balloon, and after that, show the result. So we are not imaging this thing because it's very apparent how to go ahead. So we'll just deploy a stent. We have taken Medtronic Onyx 3 into 15 stent, and now after deployment we intend to dilate post dilate with a 3.5 into 8 balloon. So just positioning my stent. So so we've deployed the stent. uh, Normal is 12, so it's fine. Just a minute. Fluorosafe 15 seconds, 20 seconds down. The stent looks well expanded and very well opposed with the vessel wall. So there is a bend. I think the stent is very well expanded. This is a bend, and I think we have got a desired result. So that is it. I will just post dilate slightly more here at the lesion site. Just inflate. 10, 12, 13, 14, 15, 16, 17, 18. Down. Down. Yes. So 3.5 balloon. I think we have got the desired result. So just taking out the balloon. So this is the IVS which we have taken across the lesion. Yes. Fluorosafe. Start. So this is there is a bridge, and now we are coming back. The stent has started. It is very well expanded, well opposed. Here also, I think there is a residual plaque burden, eccentric, but the overall result looks good. I think the lesion part is slightly under expanded. I think otherwise we have got a fairly good result. The plaque burden is less than 40%, and we have got a good expansion of the stent. So I think we'll just post dilate the distal segment slightly bit more with a 3.5 balloon. Otherwise, rest of the stent segment looked apparently fine. So I think it is a good result now. Yes, it looks apparently very well expanded and opposed. The wire entry was slightly difficult, but finally we have been able to enter. Just taking a small shot here, just to show, because later on, yes, fluorosafe. So we are taking an IVS run of LCX to LM now. We are interested in seeing two things: plaque burden in LCX, distal proximal reference diameters, and the left main dimensions as well as the plaque burden in left main. So we have passed our IVS catheter across the circumflex lesion, and now just save a fluoro. Now we're going to just take a pull back across L6 to OM. So we're starting. So the distal vessel is 3 mm. Here it looks around 3.5. So coming back, no plaque yet. No, the plaque has started. Looks more lipidic plaque, and once we yes, fibrolipidic plaque, there is no calcium, and you can see the plaque burden is significant. I think the angle is good, and we don't have any significant disease in the left main, distal left main. So I would personally, because in majority of the cases which we do without imaging, especially we tend to do it from LM to the target lesion, LM to L6 or LAD, and imaging is mandatory for these lesions because you have to see that there is plaque in left main or not. But in this, you can see the plaque in LCX is definitely there, but there is no plaque in the distal left main. So I think we can try to nail the ostium, and hopefully we should be able to do that. Just coming back, this is the area, this is the point of polygon of confluence, and you can see that there is some plaque here, but just pull it slightly back. Just. This is the no. Across towards the left main. Yes. You can see that there's no come back. Yes, there is no significant plaque in left main. So I think this is, if had there been significant plaque, I think we would have gone with LM to LCX. But in this case, probably considering that he had an anterior wall MI just 3 days back, I think it's better for the patient as well as for us also, frankly speaking. So the point is whether we will be able to nail the ostium or not. That's the only thing now. So 10, 12, 14, 16, 18, 20. I think looks good, huh? Down. So we've taken a 328 stent with an intention to, with a plan to post dilate it with 3.5 or 3.75 as per the IVS findings later on. So we will try to nail the ostium. We thought that Jabos would be an option, but there is no long-term data with the safety of Jabos, and so we are going ahead with nailing the ostium. We have a wire in ready with for our reference, and sure. Yes. So this is looks to be our desired position. Just take a scene. That is what we want. So even if it occurs, I think not more than 1 mm protrusion will be there. So just show me the apicaudal view as well. Just change to apicaudal. Show. Looks good here also. So uh, see RA caudal. Just a minute. Show. Looks good in this also. So go back to the LA caudal. Save the fluoro. I think we are good to go. And the LA caudal projection we will inflate the stent. I think we have nailed the ostium. The marker is at the, yes, down. So take a stent boost, that stent vessel whiz. I think it looks good. Looks good. We've almost nailed the ostium. So inflate. 16, 18, 19, 20. Right. Down. inflate 14 down. I think we are done. Yes. This is the result which we have got, and I think angiographically it is an excellent result. You can see stent is very well expanded here. It is fine. The result looks optimal here also. It is, I think MLA here is acceptable. I think we can dilate a bit more here. Well expanded, well opposed. I think looks good overall. Coming near the ostium, I think here also we have achieved a good MLA. So we are so I don't think there is significant protrusion into the left main. So it's a very very nice result. I think only zero point 0.5 to 1 mm protrusion if you can see. Fine. Just a minute. This is pulling back, pulling back. So I think I need to post dilate a bit more here. And now we are nearing the POC. I think hardly a strut into the left main. So it's a good result even on IVAS also. You can see that this is the exact what has happened in this case, and we got a very good result with minimal degree of protrusion into the left main. So just inflate it here again. 16, 18, 19, 20, 21. ठीक है. Down. So I think we have got a good result on imaging as well as angiographically. So this was a difficult decision to make whether we should go with a crossover strategy or try to nail the ostium. But I think probably we chose the right option and got a good result. So I'm just taking out the wire and everything else. So this is the final result which we have got. I am sure that we will have a lot of questions and a lot of discussion regarding the choice of nailing the ostium versus LM crossover stenting. But I think we will have a good discussion. Thank you so much from all of us here. So we got a very very good result, and I think I must thank all of you, especially the Medtronic team, who actually helped us do this such a case and do it live in front of good audience in a peripheral place like Mandi. We actually this hospital is called Himachal Heart Institute, and it is located in Mandi. You must have heard about Mandi because of floods which have occurred in Himachal. Devastating situation it was. But now we've started working back again, and we hope to create a difference in this peripheral part of India. Thank you so much.